Hey guys, we totally get it. COVID has put a tremendous wrench in the shadowing experience. Who can shadow like they used to during a pandemic? So, MedSchoolCoach has come up with an exciting way to learn about medicine and a great way to get a shadowing-esque experience since COVID significantly limited in-person shadowing. We have the Virtual Shadowing Podcast, which is a new podcast where physicians from many different specialties are interviewed about their experience in medicine and then talk through several interesting patient cases.
Thanks for that intro, Dr. Derone. My name's Sam Smith. I host this new podcast, and what I'm going to do is just play a full episode of this podcast for you. If you find it interesting, go ahead and search Virtual Physician Shadowing in whatever podcast app you're using and subscribe. Virtual Shadowing by MedSchoolCoach brings you up close and personal with physicians from many different specialties. Walk through tough cases with each doctor and learn about their triumphs and the challenges that they face on a day-to-day basis. To view the video that this audio is from and to take the quiz that is associated with each podcast, visit shadowing.medschoolcoach.com. Our goal here is to provide pre-meds with a shadowing clinical-like experience. It's a little bit tough right now to get because of the COVID pandemic. My co-host and I, Dan, are joined today by Dr. Sahil Mehta. He is an interventional radiologist and also on the faculty at Harvard Medical School. Now, with that said, Dan and I are going to spend about the first 15 minutes or so kind of just talking to Dr. Mehta, getting to know him. And then after that, he's going to give us some interesting cases. So first of all, Dr. Mehta, really excited to have you here. Thanks for joining us.
Yeah, Sam, thanks for having me. I mean, this is super exciting. I love talking about interventional radiology. I think it's the coolest field in the world. So I'm excited to talk to everybody about it and hopefully pique some interest of students out there. I know it's real tough right now to basically get some of the exposure. And so it would be awesome for you guys to come with me into the hospital and get that exposure. And so once you have that chance, I definitely recommend it, but we'll try to replicate it as best we can here.
Good. So I just want to start with the most general question here is, why did you choose a career in medicine?
Why did I choose a career in medicine? I was an engineer in college, and I went through the process of thinking through what I wanted to be. And I really wanted to be a rocket space engineer. I really wanted to be an aerospace engineer. Like that was the thing I wanted to do. I was super psyched about it. And I basically wanted to design space shuttles and those kind of things. And so I was going through that process. And then I realized that actually the thing that you do as an engineer was not design the entire airplane or the entire aircraft or the entire rocket ship. It was more designing like the little nut or bolt on the thing as part of the whole thing. And so it didn't take for me as well as I wanted it to, although the skills I learned in engineering and sort of the thought process was definitely really important. And then so I sort of started searching around. My father was a physician. I had a lot of people in my family who are physicians. And so my initial reaction was absolutely not, I'm not going into medicine. That's the last thing that I'll ever do. But as I sort of went through the entire process, I found myself gravitating towards a profession and a field that I would come home at the end of the day and feel good about what I did. I'd come home at the end of the day and really feel like, okay, you know what? I made an impact in somebody's life, or I was able to really, change somebody's life, make a difference, whatever it might be, like really just be able to truly impact, a person. And I felt that there was no field that you can really do that in as well as medicine. Now there's a ton of other places. Like I thought about education. I thought about, being a teacher. And I really thought that was something where you could come home at the end of the day and really feel like you made a difference. And so that's what I wanted to do. And I found myself intrigued and fascinated by a lot of the stuff within medicine, right? And medicine is an applied science at the end of the day. It's probably the most, I don't want to say biggest, but like one of the, best applied sciences out there, right? You take your knowledge of science and then apply it to being able to really make an impact in somebody's life. And so I started thinking through and saying, okay, maybe medicine is where I want to go. And so that's sort of where I ended up. I really wanted to make sure that I came home at the end of every day and said, you know what, I helped somebody. This was something that I was able to do when people are in their time of need. they turn to physicians, right? Like there's not a more vulnerable, unfortunate place to be than when you're sick. And physicians and the healthcare system and all of us who take care of patients are sort of where people turn. And that's a feeling that I don't think can really be replicated in any other profession.
So how was the transition, right? So if you studied engineering in college, that kind of thought process is sometimes different than the thought process that you have maybe in medical school or as a physician.
Yeah.
How was the transition from engineering to then going to medical school, where a lot more of the information was like other kind of science based?
I will tell you an anecdote. And yeah, so I'll tell you this anecdote on it. First of all, the answer is it was rough because in engineering, it's all about sort of thinking through a problem, not memorizing anything, really understanding where you have to, understanding how to get to a solution, right? And medicine is like that. But the first 2 years of medical school are not like that.
Yeah.
First 2 years of medical school are memorize, right? That's the first 2 years of medical school. And so as an engineer, I came in, I was psyched. I was able to think through problems. I was able to find creative solutions to things, which again, like when you practice medicine, that's actually a lot of what you do. But in those first 2 years, right. Oh my God, it was rough. And I'll tell you, my first anatomy test in medical school, I failed, literally failed. And I came from Columbia. I came from an engineering background, and I graduated with a 4.0 GPA from college. And so I wasn't a dumbass, right? Like I came in and I knew what I was doing, and I failed my first test in medical school, and it kicked me in the butt, right? And it was one of these things where I was like, oh, wow, this is going to be different. This is sort of a different way of studying. It's a different way of learning. And it's because you have such a vast amount to learn in such a quick amount of time. And so your first 2 years, you really sit down and just hit the books and sort of memorize. And then once you get to your third and fourth year, once you get to residency and beyond, now you're sort of applying the things that you've gotten that foundation on. And that's when I was really able to sort of get back to excelling. But it's a really legitimate question, because the first 2 years, particularly the first year, particularly the first couple of months in med school, were rough. There was like, wow, I got to memorize a stack of books this big. You know, that's what this is. That's interesting. But that's sort of what medical education
right.
was for years and years. I think it's moving a little bit away from that. You know, but there's still just a ton of information that everybody has to know.
Right. And anatomy was one of the toughest courses for me as well. I remember having to sit and memorize all of the different muscles and bones and where are the attachments and everything like that. So I definitely see where you're coming from, where anatomy is just this like boatload of information that you just have to memorize and try to understand at the end of the day how things work. But you can't really get past the fact of you need to memorize this information first. So it can definitely be very difficult. And it was one of the tougher courses for me during medical school as well. So once you moved past that, once you got through most of the years of medical school, how did you go about making the decision to go into interventional radiology?
Yeah. So, you know, I was a lost soul in my fourth year of med school, right? I'll be honest, I was a lost soul. I came into med school thinking I was going to be a pediatrician. I love kids. I love taking care of kids. I thought it was a ton of fun. Mm-hmm. I went through my rotations and I said, oh, wow, I don't really like general pediatrics. This isn't a lot of fun. This is not what I wanted to do. While I still like the cute kids, I just didn't like sort of the role of a general pediatrician. Thankfully, there's a whole bunch of people who do, and they're really good at it. What I realized was that I like to make an impact. I like to work with my hands. I like to make a fast impact. I like to see patients and diagnose patients and treat patients sort of and see the immediate results of that. Mm-hmm. And so for me, I was thinking through things like emergency medicine. I was thinking through ophthalmology. I was thinking through interventional radiology. Like those were the couple of fields, orthopedic surgery as well. Like those are the fields that I really thought, okay, these are the things I could see myself in. And while each of them is different in their own way, they all sort of had a component of I could make an immediate impact on somebody and see that impact really right away. And so as a fourth year med student, I was a little bit lost. I thought about all these things. I did rotations and all these things. And then I kind of came to the conclusion that there was a couple of fields that I really liked. And one of them was vascular arterial pathology. I really found that really fascinating.
Right.
And I found cancer really fascinating. And actually the things that I feel that was able to put that together was interventional radiology. I'll go through some cases that kind of show that. You wouldn't think that, right? You wouldn't think interventional radiology in terms of like cancer, but it's actually like I treat probably 5 out of 10 of the patients I treat on a daily basis are cancer patients in some way or another. And so that was, it sort of gravitated towards that field because of that reason. I also really like toys and the cool aspects of it. But it's not easy. I tell med students all the time that I think the hardest thing to do is pick a specialty and find a specialty. And a really good piece of advice that I got, and this goes for pre-meds or med students or whomever, is find the thing that is most boring about a specialty. Don't find the thing that's most interesting, because every single specialty has something that's super interesting, right? Every single specialty has something that's super interesting. But find the thing that's the most boring. Do you like that really boring thing? If you do, that field is for you. So I'll give you, like, I was shadowing an ophthalmologist at Memorial Sloan Kettering between my first and second year of med school, because I thought ophthalmology is what I wanted to do. And I was seeing these retinoblastoma patients. Retinoblastoma is a pretty rare eye cancer. And I was seeing all these patients. He was doing these incredible surgeries, and he was actually the one who gave me that advice. And he said, you know, you have seen more retinoblastoma patients in this 2 weeks that you spent with me over the summer than 99.999% of ophthalmologists will ever see in their life. He's like, you might think this is really cool, but do you think that staring in front of a patient and saying which one is better, number one or number two, when they do that little eye exam, is cool? If you do, then ophthalmology is for you. If you don't, then don't choose ophthalmology, because these retinoblastoma patients are real cool. So I thought through that, and that was actually really interesting to me, because for me, interventional radiology, like the most boring thing I do on a daily basis is place a central line. Like that is, I've done thousands upon thousands upon thousands of central lines. I could do it literally with my eyes closed. It's the most boring thing I do. But I saw in other specialties, like that was a huge deal, and they were really excited and they were really psyched about placing a central line. And it was something that they were really excited about, like the ICU or the emergency department. Like when they were placing a central line, they'd be like, oh, we get to place a central line. This is so cool. And again, as an IR, that's like the most boring thing I do. And so I realized that this was a specialty for me. Now, for other people, it's like, well, managing the vent might be the most boring thing I do, or at least that's like intellectually stimulating for them. For me, it was sort of that procedural aspect. And so that's why I ended up choosing interventional radiology. So I think for everybody, you know, particularly for pre-meds, right? When you guys are thinking through this and you see a specialty and you're like, oh, that was really cool. Keep in mind that may be just 1/100th of what that person does on a daily basis, right? Like you got to think through like what really is their life like at the most boring aspects of it. And if you like that, then that's the field for you.
Yeah. I was curious I don't know what placing a central line is. And maybe, do you have said this in your slides? Because if so, that might be a good transition for your slides. But if not, you know, what is placing a central line? What does that mean?
Yeah, I don't. So it's a great question, right? So let's back up for a second. So what is a central line, right? A central line is basically an access point to give drugs, to take blood. It's one of these things where when you're in the hospital, a central line can be really important, right? So when you go to, let's say you just go to the ED for a small cold or something like that, you might get a peripheral IV placed, right? Everybody knows what an IV is. They've seen that. That's a very small bore catheter. It's really small, and you can inject things like saline through it. You can inject things like contrast or blood through it, but it's pretty small at the end of the day. And it's not an access that we want when somebody is super sick. So when somebody is super sick, what you sometimes need to do is get them drugs really fast, get them blood really fast, get them volume or saline really fast into their body, right? Like they might be bleeding from somewhere and you need to get them blood super fast. And a peripheral IV is just too small to do that in a way that for critically ill patients. And so sometimes what you need is what's called a central line, where literally you'll go in through a vein in the neck and put a catheter. It's about this big, at the end of the day, it's a couple of millimeters big, but it's essentially a big tube that goes from a vein in your neck directly into your heart. And so at that junction, I can now give a whole bunch of drugs really quick. I can give a whole bunch of blood really quick. I can draw blood really quick. And you'll see this a lot in emergency situations, right? Somebody is crashing on the table and they need what's called access, some kind of venous access to give drugs, to give blood. And that's what a central line is. A central line does that. You can go through the neck, you can go through the groin. There's different ways to sort of place that. But basically, it's a quick conduit right to the heart. And it's a long catheter or tube that essentially just stays there. And when you're done with it, you take it out. Hopefully the patient gets better. You can take it out and you basically hold pressure, and that venous hole essentially just closes up. So that's something that you'll see emergency medicine physicians do a lot. That's something you'll see ICU doctors do a lot because those are critically ill patients. Interventional radiology does it a ton. Interventional radiology oftentimes is the one who does it when the ED doc or the ICU can't get a central line for whatever reason. If the anatomy is really difficult, if they have had previous central lines and that vein is really scarred down, because that can happen, they'll call IR and say, hey, we need your help putting the central line in. And we're the ones who sort of can go up there and place a central line really in any patient in any way. We can get them access. So central lines are something you'll see a lot in the hospital, particularly in the ICU setting, because those are really for some of the most ill patients that are out there.
Gotcha. Makes sense.
And as I said, that's like the most boring thing I do. Central lines are super boring for me, right? We can place central line in anybody, but it's definitely one of those things that I remember as a med student and even as an intern, I remember seeing fellows place central lines and being super excited and being like, oh man, I want to do that. I want to do that. Like, just let me get my hands on that. And now, again, I've placed no less than 20,000 central lines in my relatively short career already. So it's something that, we just kind of do on an everyday basis at this point.
Great. So in terms of your everyday basis, do you kind of have a way to talk about what you do on an average day? Is that in your slides? Could you prepare that for us?
I definitely walk you through it. I have some of that in my slides too, but what I'll say here is that interventional radiology is a pretty varied field, really like any specialty, right? Depending on where you practice and how you practice, it can be practiced very differently, right? So my day as an academic interventional radiologist looks very different than, let's say, a community interventional radiologist, maybe in the community in a rural location. We have the same skill sets, but sort of the things that I do on an everyday basis may be quite different. They may be doing some diagnostic radiology as well. They may be doing biopsies and drains. These are things that I can do as well. But at sort of a tertiary academic center, we're sort of doing a lot of the more complex things here as well. And that, again, that goes for any specialty, right? So if you're a general surgeon out in the community, you might be doing relatively more quote unquote routine, super important still, but more sort of routine procedures. Whereas if you're at a big academic center, maybe you're doing the more complex things. So a day in my life, maybe involves 3 or 4 central lines. It may involve 2 or 3 arterial embolizations. It may involve a TIPS procedure. All these things we'll go over and sort of dive into. And it's going to involve seeing patients on the floor, talking to patients in clinic, seeing follow-ups, talking to clinicians. All these things are sort of part of the day of an interventional radiologist.
To receive 1 hour of credit for the shadowing experience, take a brief 5-question quiz at shadowing.medschoolcoach.com. Pass the quiz and you'll receive a certificate of completion from MedSchoolCoach. Now, back to the show.
I think this is the best way to describe interventional radiology, right? It's like surgery, only magic. It really is. Like, the things that we're able to do are very much like surgeries, right? They're minimally invasive surgeries. In fact, there's an entire group of interventional radiology that probably calls ourselves more minimally invasive surgeons than radiologists. Now, interventional radiology is typically considered a subspecialty of diagnostic radiology, although a couple of years ago, actually, interventional radiology started having its own residency. So now if you're a med student, you can actually go right into interventional radiology. It's still certified by the same board, but basically it's something where we as interventional radiologists do not necessarily do the same. We don't actually do anything like a diagnostic radiologist does on maybe an everyday basis. So it's kind of a different field. And I would consider it more of a surgical subspecialty than a subspecialty of diagnostic radiology. At least that's the way I sort of look at it. And what makes IR awesome? I think what makes IR awesome is really we have this attitude of we can do it, right? I think interventional radiologists are often the last line of defense. And what I mean by this is there's so often on an everyday basis, it's like, well, this patient is too sick for us to take to the OR. Or, hey, we couldn't get that central line in. Can you help us out? Or, this patient basically is going to die. What can you do? Like these are everyday conversations. And as interventional radiologists, we're often the last line of defense in the hospital. And it's like, well, yeah, let's try something. We can do it. And the reason that we can often do something is that interventional radiologists definitely think outside the box, and I think are the ultimate problem solvers. And that's kind of, I talked about it as an engineer, sort of thinking through, hey, what at the end of the day is sort of applied science, and what problems can I solve in front of me? Like interventional radiologists are really a good interventional radiologist can think through these problems and think outside the box and really come up with incredibly unique solutions to different issues. I mean, we have a procedural skill set that's really unmatched by any specialty. So there are other specialties that will do some of the stuff we do and have endovascular skills, for example, cardiology, neurosurgery, vascular surgery, all do things that are endovascular related, right? Catheter and wire skills. But the skill set of the interventional radiologist is that plus so much else from a procedural standpoint. Now, I can't crack open a chest and, tie a thoracic aortic graft like a vascular surgeon can, of course, but I can think about ways to treat this through maybe an ultrasound procedure combined with a CT and being able to get to the smallest arteries in the body with a catheter and essentially put a coil there or something along those lines, right? So the procedural skill set that we have as interventional radiologists, I think, is really unmatched by any other specialty. And then I think what's so cool about IR is literally I take care of patients across the spectrum. And that really means like pediatric patients. That means patients who are dying on the table. Like literally this patient is going to die on the table pretty much every month. Unfortunately, we have a patient who dies on the table because they were so sick and they needed an IR procedure and they unfortunately didn't make it. At the same time, I treat patients who say, you know what, the vein in my leg is bothering me when I wear a swimsuit. Can you help me with that? So we do like cosmetic procedures, right? So this like entire spectrum of procedures that an interventional radiologist can do, and the types of patients we take care of is just so varied. And that's one thing that's really cool to me about it. It's there are other specialties that are very focused, right? And that's awesome because they're super focused on just that and that problem over and over again. In IR, we're focused on problems of the vascular system. We're focused on problems of the brain. We're focused on problems of the GI system. We're focused, like, it's just all over the spectrum of what we can do. Again, from the sickest patient who's dying on the table to literally that patient who says, again, like these varicose veins in my legs are kind of unsightly. Those like spider veins that you get, the veins in your legs that kind of look funky, and you wear a swimsuit and you don't like them. Like we treat those, right? That's some of the stuff that we also treat. So it's like this wide spectrum of things that we treat that I think makes it super exciting.
Now, do you have a most common type of patient or most common ailment?
I would say no. In my own practice, I'm super subspecialized. One of the type of patient I treat a lot is through a pretty rare procedure called a prostate artery embolization, where patients who have benign prostatic hypertrophy, right? So this is basically their prostate gland has swelled in size, BPH, right? This is something that happens in really all men. Unfortunately, as we get older, your prostate gets bigger. As your prostate gets bigger, the prostate sits between the bladder and the urethra. Or the urethra actually courses through the prostate. It sits between the bladder and the penis. And the urethra, which takes the urine from the bladder out the penis, ends up getting squished essentially by a big prostate. And when that gets squished, you end up getting a lot of symptoms. Like you get up very often at night, you go very often. So it's a really common problem, often treated by urologists, but I can treat this with something that's called a prostate artery embolization. So that's me at an academic center having a pretty very subselective small procedure that I do very, very often. There's probably only 2 or 3 other people in the country that are doing as many as I am on that. But that for an IR in general, they are treating literally, across the spectrum of things. And I'm also treating across the spectrum of things. So it's really, there's not like one procedure that any IR, you can go to 3 different IRs and they'll tell you they do 3 different procedures the most in any given day, right? Or really Gotcha. 30 different IRs and they might tell you 30 different things that they do. So it's really varied in that way. And so we've been talking about these procedures, and I put some of these pictures in because this is literally what it looks like. Like, these are my hands on an everyday basis, right? Like, this is what I'm doing all the stuff that I just talked about and will talk about through. Like, I'm literally doing it through these little wires and catheters outside the body. And it's, that's why I think it's really magical at the end of the day. Like, this is all I'm doing, manipulating wires, manipulating catheters outside the body. And with that, being able to solve all these problems. And so you can see, we get a little bloody, but we're not cutting people open. We definitely have blood on the table. Blood comes out of the arteries and those kind of things. But it's we're not doing big open surgery. Instead, we're being able to do it literally through these wires and catheters at the end of the table. And that's all it is. Like, this is all that's inside the patient. I'll even show you a picture. Here you go. This is what's called a sheath. This is an instrument that basically is a big IV. It's a slightly bigger IV. It's not a huge IV. It's like, you can kind of see the size of it. It's not that big, but this is literally what I do all my procedures through. This little thing called a sheath is what I can do all my procedures through. And you can imagine at the end, you just put a Band-Aid on top of the patient and they're sort of done, right? This is what it looks like. So you're working with your hands on a second by second basis. That's what you're manipulating. You're manipulating these wires and catheters. So that is, when you say it's a specialty that works with your hands, this is what it means, right? You're really a specialty that works with your hands in that way. And the skills you need to sort of like develop a wire feel and understand where to navigate these things through all come based on like tactile feedback from these wires, and how it feels inside the body at any given time. This is what a room looks like, right? So this is my operating room. This is what I walk into. And so you can see it's pretty futuristic in some ways, right? This is where the patient would lie, right? This is anesthesia stuff. Sometimes we do this with these procedures with anesthesia, but a lot of times actually we do it completely without anesthesia, which is the other incredible part of all this. We can do all these procedures with literally only local numbing medicine or some sedation medicine. And then you see all these big screens, which is kind of where I'm looking and understanding what's going on at any given time. This is kind of what it looks like, right? So this is us sitting there. We are manipulating these little wires at the end of the table. And what we see on the screen is basically fluoroscopic images or X-ray images, sometimes CT, maybe ultrasound images of what's going on inside the body, right? So I'm actually watching my wires and catheters go through the body. I'm watching them sort of take turns. This is an aortogram, and basically you can see that these are the vessels that would be supplying your leg. And you can see, like, on this side, this person has pretty good flow. But where is it on this side, right? It's completely gone, basically. And this is somebody who, for instance, would basically be presenting with leg pain because they have severe arterial disease, right? Their arteries are clogged up. Your arteries get clogged up with calcium. They get clogged up if you're a smoker. And one of the things we can do is open these back up. So we would actually go through and get back and then be able to stent these areas open and increase the blood flow to the legs. So that's something that's very, very commonly done, right? And we're doing all this through like this tiny little pinpoint hole. But this is sort of what we look like on an everyday basis. Like, this is where we're gowned up, we're garbed, we're wearing lead underneath to protect ourselves from the X-rays. This is the X-ray machine that's using. Actually, in here you can even see a CT machine in the back. So sometimes they have a CT and X-ray sort of combined, or an MRI and a X-ray combined, and it's super futuristic in that way, right? I mean, this is like, you're literally peering inside the body as you're doing this without cutting anybody open. Like, it's pretty wild.
So who's in the room with you typically? Like, when you're doing these procedures, is it just you? Like, do you have a few people helping you, or, who's involved?
Yeah, great question. So there's a bunch of people typically in an angio lab or a cath lab. These are different things that we can call our OR suites, right? And so there's typically the person who's operating the wires. There's an assistant who, in my case, is often a resident or a fellow who's training. There's a tech, right? The tech is the one who we basically have thousands of wires and thousands of catheters that we can use. And so they're all lined up along the wall. And we say to the tech, hey, I need to go get a Simmons. Can you go get me a Simmons catheter? And they open it up for you, right? Oftentimes there's a nurse in the room who's monitoring the patient's vital signs, right? As you're going, there might be an anesthesiologist in the room if the patient's super sick and needs some things like pressure support, which is basically they're really sick and they need drugs to basically keep them alive at that moment until we're able to stop the bleed. So these are some of the people that are in the room with us at any given time.
All right, cool.
So my day as an interventional radiologist, right? I mean, I will go through a bunch of stuff here, right? And basically on any given day, I get in around 7 or 8 o'clock, and I go through inpatient rounding, right? So I see patients who are in the hospital who perform procedures on, or who maybe we've consulted on, right? Maybe there's a medicine doc who said, hey, can you take a look at this patient because they had a GI bleed last night? I want to see if you can do anything. And I tried to kind of put on the spectrum of patients, right? It could be a young, healthy patient who came in with trauma, right? They got their car accident and they had a splenic laceration, right? So their spleen was bleeding and we needed to do something. IR can do something about that. Or maybe an OB patient who just gave birth and they can't stop the bleeding after the birth, right? The placenta, basically the uterus isn't contracting in the way it should. And so the patient is still bleeding. And so we can help that person by doing an embolization. They're patients with cancer, right? Maybe they just need something as simple as venous access, or maybe they have a blocked bile system and the GI docs couldn't get to it or couldn't access the anatomy. Maybe they have a liver cancer, which we can do something called an ablation or an embolization on. They may be liver transplant patients, right? They just got into this big transplant and unfortunately their artery went down, right? So there's an artery that connects the transplant surgeon got out of the OR and said, oh man, there's like no more flow in this artery. I need you to open this back up. So you can see like just a wide spectrum of patients that we can sort of work on a daily basis. And literally these are patients who would be on our, what we call our list or what we round on a daily basis. And so I'm seeing patients, I'm interacting with patients, I'm interacting with the referring physicians. Then we'll typically start our procedure day, and it could be, a bunch of outpatient procedures, right? A uterine fibroid embolization, a transarterial chemoembolization. So this is treating a patient maybe with fibroids, a young, healthy woman with fibroids. This is treating somebody with cancer. I talked a little bit about the prostate artery embolization, which is something I do a lot of, treating an older man with urinary symptoms. Peripheral artery disease stenting, like it just goes on and on and on. Some of the stuff that we do. And again, it's so varied on a day-to-day basis. There could be biopsies thrown in here or drainages, right? So biopsy is when a patient maybe has a tumor or something that they see on a CT scan, but we don't know what it is, right? And so we're not going to cut them open and take that out before we know what that is. We need some tissue for our pathology colleagues to sort of look at it under a microscope and say, okay, what is this? This really is cancer, or this is not cancer. Maybe it's something benign. And so we're able to get to those areas and actually biopsy them without cutting the patient open, right? We're just able to put a small needle in, take a small sample, send it off to our pathology colleagues, and then they look at it and say, okay, yeah, this is X or Y, and then we treat them accordingly. We'll typically do a couple outpatient procedures in a day, and then a lot of IR is actually based around inpatient procedures. And so people in the hospital who are super sick or have come in, right? Trauma cases, people who are bleeding out, people who have infections or clots, and the clot could be in the brain, it could be in the arms, it could be in the legs, it could be in the lungs, aneurysms, like these are all things that we sort of work on. And then in between, I'm seeing patients on the floor, I'm discussing, their conditions with referring teams. And then in my practice, one day a week, I basically have clinic time where I'm actually doing no procedures. I'm actually just seeing patients, right? And these patients 100% consider me their doctor. And I think that's a important sort of consideration, right? There are specialties where you are a subspecialist or somebody behind the scenes, right? Where maybe you're not necessarily considered that person's doctor, although you have incredibly important role in that person's care, right? Like say a diagnostic radiologist or a pathologist, right? They're sort of behind the scenes and helping other doctors understand what's going on with their patients. But an interventional radiologist, I'm actually that patient's doctor, right? I'm seeing that patient, I'm talking to that patient 100% considers me their doctor, which again, I think that's sort of why I really like IR, because I get this whole spectrum of things, right? I got clinic time, I get procedural time, I get super sick patients, I get well patients, I get really the entire spectrum of things. And so, what I wanted to do was take you guys through just a couple of cases, right? To think through like what this looks like. I'm going to create some new pathways. I'm going to fix an aneurysm. I'm going to stent a venous obstruction. I'm going to open up veins that have been clotted for years and restore intractable pain, right? So these are 5 different cases that I thought just capture, sort of an everyday life in interventional radiology. And I can go on, I could have 50 cases that are interesting like this. This is just a small version, but here's the first case, and maybe Sam and Dan, I'll rely on you guys a little bit to think through, what you guys are thinking. Dan, you being a 4th-year med student, I mean, 46-year-old man comes up coughing up blood. Like, what are you thinking?
So I'm thinking, why would he be coughing up blood? There are several different reasons for this to be happening. Did he tear a part of his esophagus? Does he have like a superficial or even a deep tear? Does he have some sort of varices? Like maybe he's a chronic alcohol user who has varices now in the esophagus and might be coughing up blood from one of those ruptured varices. It could be a lot of different things like that. Maybe he has a gastric ulcer even. So there's a lot of different things that could be causing this.
Yeah. So that's exactly right? So there's a lot of different things that have been causing somebody to cough up blood. And what you guys just saw Dan do was sort of go through some of what's called a differential diagnosis. And he's going to ask that patient some more specific questions, right? Like, hey, how much you drink on a daily basis? The patient says, I never drink. Well, it's probably going to put you down one category. On the other hand, if the patient says, I drink a pint of vodka a day, it's going to put you down another category. And so as a physician, as a med student, these are some of the things where you see coughing up blood. It can actually be caused by a huge amount of different things, right? And the goal of a clinician is to actually nail down what's causing that. And so I, as an interventional radiologist, may actually not be involved in the nailing down of that. Actually, that's more of maybe the emergency medicine doc or the internal medicine doc who's taking the initial history of things. But they may call me later when they say, okay, you know what, this is due to varices. And so just want to take you guys through why this may happen, right? And so let's say that this guy said, you know what, I'm drinking 10 pints a day, 10 beers a day for the last 30 years, right? You're kind of really thinking that this guy has liver problems at the end of the day. And liver problems and coughing up blood very much means that this person has varices, most likely, right? So what are varices? Sam, have you ever heard of varices?
No, never.
All right. So let me kind of take you through what this looks like, right? So the body has this incredible way of adapting to different situations, and varices is an adaptation to a bad situation, right? So this is your liver, right? And the whole point of your liver is to filter out blood, right? So anything you eat basically goes through what's called your mesenteric system, and the nutrients and everything else, nutrients and good stuff and bad stuff, essentially come back through the mesenteric system, right? This is kind of an oversimplification, but I'm going to go with it anyway. Basically, the blood, when you eat something, needs to be filtered before it goes back to the rest of your body, right? So if you've eaten toxins, if you've eaten something that the body doesn't like the liver is your filter at the end of the day for those things, okay? And so what happens in a normal situation is your blood, the nutrients that the blood needs will come back. These little red dots are blood. It's going to come back. It's going to be filtered by the liver, and then it's going to go up the hepatic veins. And actually, your heart would sit up here. And it goes into your heart, and then your heart pumps, and then it gets it to the rest of the body, right? Actually goes to the lungs and then gets to the rest of the body. So that's basically what happens to, that's what your liver does. It filters out toxins at the end of the day, right? And simplification is your liver filters out toxins. What happens when you drink a lot is that your liver ends up being crappy, right? It ends up sort of not working the way it should. And so instead of filtering out, it becomes hard. And as it becomes really hard, what happens is that blood can no longer flow through the liver in the way that it's supposed to. And so instead, what happens is that blood goes up, and it actually, like, the liver kicks it back out. It's like too high resistance for it to go through the liver. And so what it does, it actually goes through veins that are really not supposed to be there, or were there when you were a baby. There's this whole other talk probably on OBGYN about this incredible, what's incredible about, like, the fetal circulation. It's really cool. Basically, the fetal circulation is sort of almost reversed compared to the adult or even pediatric circulation. So when you have a placenta, things go opposite directions. And I'm not an OB, and I'm not going to talk about that because I don't remember any of that. But basically, there are all these different pathways that open up, and one of them is like the coronary vein, and this is the stomach. These are what's called short gastric veins, and basically they will kind of go around the stomach or the esophagus. And so in a normal situation, you don't have all these veins, and they're not very big. But in an abnormal situation, when your liver can't filter out the blood, essentially these get really big, okay? And so what happens is that these get really big, they sort of hop around and go around the esophagus and stomach, and these are what ends up bleeding, right? And that's what's called a varix. A varix is basically an abnormal vein, something that is dilated to a area where it shouldn't be and can easily cause bleeding, right? The blood's got to come back somehow, right? And it comes back through these different pathways. And so there's a lot of things that people can offer this patient, right? So the medicine ED team, they can fluid resuscitate the patient, right? Let's say that they're dying on the table, their blood pressure is low. Maybe they placed that central line we talked about, right? And they gave them a bunch of blood real quick to get their blood pressure back up. They can start drugs to pressure support and constrict the system to make sure that essentially the brain gets enough blood so that the person doesn't die of brain damage in the meantime. Our GI colleagues can do a lot of stuff with these varices, right? They can actually go in through the mouth and they can band a varix. So they can see a bleeding varix and they can band it. They can place what's called a Blakemore tube, which is essentially like a really big balloon to stop the bleeding at that juncture. And then there's also some surgical options, but the surgical options aren't really very good in the short term, right? So if this person's like coughing up blood, you can't go get them a new liver and place it into their body right away. Liver transplants take years to get, so this patient may end up being referred to IR. And what I think is really cool is what I'm going to do for this patient is I'm going to create a new pathway, right? So here's how I'll talk to the patient. I'm going to save your life by having your blood bypass these bleeding veins, by creating a new pathway for the blood to flow through, by blindly sticking a really long needle from one side of your body to the other, and then putting a stent through the liver. And at the end, I'll put a Band-Aid on your neck. Like, that is what I'm going to do for this patient. And I say this because I think that this is like the coolest thing in the world, right? So this is what's called a TIPS procedure. And actually, this is one of the ways I initially got interested in IR. I remember hearing about this in med school and I was blown away. I was like, wait. What just happened there? We were able to save this patient's life who was bleeding from a varix and create this whole new pathway through the body. And then put a Band-Aid on their neck at the end and they walk away. Like, that blew me away. And so this is what's called a TIPS procedure. And essentially, this is the liver again. What we do is we come down through the neck and I find the hepatic vein, which is the vein that essentially drains the liver. And I essentially get into here and then I stick with this really long needle from the neck and I try to find the portal vein, which is that vein that brings the blood back from the bowel. And once I'm able to stick there, I'm able to place a stent through essentially at the end of it. And that stent now, instead of blood coming here and then getting to the liver and then flowing back like we saw in the bad liver, what it's able to do is able to go through here and then go through the stent because that stent is just open and a path of least resistance. And so blood can kind of flow back the normal way it's supposed to flow.
How do you find those veins? How do you know where you're at? That sounds difficult.
Yeah. So, I mean, basically what we do is while we're doing this, we understand where the hepatic vein is. Based on anatomy and based on doing this a lot, you know exactly where these things are supposed to be. You inject some contrast essentially as you go to be able to find your way. But I can tell you, right from an x-ray where I'm at. So I look at the x-ray and I look at where my catheter is, and I know exactly based on anatomy where that hepatic vein is supposed to come off. And I know it's okay, it's right there. Now, for the portal vein, oftentimes we are sticking blindly in some ways, but we know, again, based on anatomy, maybe based on the CT scan beforehand, well, it's in front of where my catheter currently is. And so I'm going to angle this needle essentially forward. And as I angle this needle forward, it should hit that. It should hit that. Like, that's kind of how we do it. We kind of know the anatomical relations of things and are able to find our way based on that.
That's awesome.
Yeah, incredible.
So this is kind of what it looks like. So, if you were sitting there next to me, like, this is what I'm looking at, right? I'm like literally staring at the screen, and this is kind of what it looks like. So I've come down. This is the heart right here. This is the liver. And we just kind of know that from looking at x-rays and understanding. And I know that this is the hepatic vein. And so this is after that tip stent has been placed. You actually see, I mean, you see that like a little ring and all these stents. That's the tip stent. That's the stent that we've placed. And what you see is that as we inject here, these are the varices. Remember I said that blood should normally flow this way and then up this way. But what you're seeing is that blood is actually flowing this way and then up this way, because that liver is really hard. And so this right here is kind of where the stomach lies. And you can imagine if you have this giant vein wrapping around the stomach or around the esophagus, that's what causes it to bleed. And so in this case, we placed the tip stent, which shoves the blood the way it should. And then we actually ended up coiling this thing and embolizing it. So embolizing means shutting down the blood flow. And we basically pack this thing with a bunch of metal coils and plugs. And then as we inject, okay, now we see blood is no longer flowing all the way up here. It's flowing back this way in the way that it should. And so this patient is no longer going to bleed from that area. In fact, the blood's going to flow back the way that it normally should. So that's a TIPS procedure. It's called a TIPS, and again, it's like one of the coolest things I think that we do. And again, I was blown away about this in med school, and now I, do this twice a week. It's one of these things where I was like, wow, this is super cool. And these are the things that we kind of do every day as IRs. So I don't know, questions. What do you guys think on that one?
Quick question.
That's crazy.
Yeah. So quick question about that then. So you said the liver is doing a lot of the filtration, like metabolizing the whatever is going through the mesenteric system. Now, when you put in this TIPS, like when you do this procedure, now the blood is just bypassing the liver. So like what's happening to the blood?
So that's a great question, right? So the blood is bypassing the liver. So not as much blood is going to the liver to get filtered, right? Because we put this tube in that essentially takes the blood from the mesenteric system directly to the systemic circulation, and we've bypassed the liver. So we can answer this question in a couple of ways. Number one, you're not normal because you've sort of unfortunately taken the normal filtration away. But in a liver patient, you were never normal, which is to say that that blood already wasn't flowing that way.
Right.
And so we look out for things and want to make sure that things still get metabolized. But some of the stuff that can't get metabolized, some toxins like ammonia, for instance, can build up in a liver patient. And ammonia, for instance, can actually build up and cause confusion, or what's called hepatic encephalopathy. So these are things that we actually look out for post-procedure. So basically, in a liver patient, you are still bypassing the liver. Some of the blood is still getting filtered through, but you're definitely taking blood and sort of putting it directly back into the systemic circulation. But most of these patients already had blood going directly back into the systemic circulation. Right. It was just going through a varix, which has a high propensity to bleed. And so we're kind of trading one system for another system, of one that we can control a little bit more and we know won't bleed, because this will bleed. This won't bleed at the end of the day.
Right. Okay.
So, here's another, case. So 76-year-old male came in with hypotension, right? Hypotension means your blood pressure is low. right? And so when your blood pressure is low, you got to be thinking about a number of things. I mean, Sam, as a pre-med, you probably have taken, people's blood pressure. When you see a low blood pressure, I mean, are you worried about anything?
Maybe they're losing blood volume somehow.
Yeah, that's perfect, right? So one of the things you got to be worried about is that they're losing their blood volume, right? They're
bleeding maybe. Yeah.
Exactly. They're bleeding somewhere. And so obviously there's a lot of reasons for hypotension, but one of them could be bleeding. And in this case, what you're actually seeing is a bleeding blood vessel. So this is what's called a CT scan, right? A CT scan is a way to peer inside the body. And a diagnostic radiologist really reads these CT scans and is able to understand them. As interventional radiologists, we're trained in diagnostic radiology, so we can read them and understand them too. Emergency medicine people can, surgeons can. Like, a lot of people are going to be able to read a CT scan and kind of get a gist of what's going on. And what you see here is, this is the aorta, right? This is like the big vessel that's taking blood from your heart to your legs, and then you see this giant thing here. That's totally abnormal. That shouldn't be there in any way whatsoever. You can see it also on a coronal plane. So this is sort of cutting. This first picture is cutting you this way and taking a look. This next picture is cutting you this way and taking a look. And so what you're seeing here is this giant aneurysm that is losing blood, right? So this person is losing blood from this aneurysm. Aneurysms can happen all over the place, in the arteries, it can happen in the veins, but it can happen in the aorta, it can happen in the thoracic aorta, like up here, it can happen in the abdominal aorta, or it can happen in these small vessels. In this case, the aneurysm is actually off of what's called the common hepatic artery. And so this is us, right? So this is what I'm seeing. As I'm doing this, what I've done is I've gone in through the groin, okay? I put that tiny little needle into the groin with that little IV, and I've inserted this long catheter, and I found my way up to what's called the celiac artery. And then I've injected the celiac artery, and I see normal artery. Okay, that is very abnormal. Arteries should get smaller as they go, right? So if you kind of don't look at this for a sec, look at this, right? So this is a normal artery, and it's like a tree, right? The branches of a tree get smaller as you go. So it gets smaller and smaller, right? Smaller and smaller. And the ones in the middle are bigger, and the ones out in the periphery are smaller. This is clearly not supposed to be there. That entire thing is not supposed to be there. This is a giant aneurysm that's bleeding and is rupturing and causing the guy to continue to bleed and die and lose volume, right? And so how do we solve this problem? Well, what's, again, so cool about our is we can actually solve this problem by, what I've done is I've put a sheath up here, and I'm about to put a stent right over that area, right? And so as I put that stent over the area, what's going to happen is that the blood is just going to go through there. It's a covered stent. So I've deployed a stent across that entire area. And now I inject again, and you don't see the aneurysm, right? Because I've totally excluded it. I've totally taken it away, because the blood can no longer fill that aneurysm, which is essentially a hole in the artery, right? So here we had a giant hole in the artery, and then I essentially plugged the hole, right? I did some plumbing, right? I patched the hole with the stent, and that's it. This is what's called a CT scan after, and you can see that big aneurysm is gone. You can see this flow maintained all the way to the liver, right? So you couldn't just go in and operate on this. If you went and operate this patient would die, right? So if you tried to cut this patient open, like, what are you going to do with this thing? It's going to burst open. It's going to bleed everywhere. This is the only option this patient had, was to be able to somehow embolize, stent, graft, or whatever else, shut that down through an interventional approach.
What's the cause of that?
So this can be caused by a lot of different things. In this case, there's a couple of clues. Dan, any idea what may have caused this?
I mean, I was thinking something along the lines of just like old age, where there's maybe weakness in the arterial walls. But I mean, I don't know. That's actually really interesting, because I've never seen that before.
So there are a bunch of causes of aneurysms, right? So one of them is certainly old age. One of them is just vascular abnormality. So young people can have aneurysms, right? One of them is prior surgeries or other interventions can sometimes weaken the arteries or cause it. Smoking, calcium, all these things could cause different aneurysms, different places. In this case, one of the clues that you have is that, what do you see here? You see this?
Yeah. Staples or something?
Exactly. Those are staples. So this patient actually had a prior surgery. This patient actually had a very recent surgery, and they were cut open. It looks like they also have an ERCP stent in. Dan, that might be interesting to you. They have an ERCP stent in, right? And so this patient had a surgery in the area of the liver previous to this, and that's what caused this this artery to open up. So there was some manipulation during surgery that unfortunately caused the artery to have an issue.
Wow. Cool.
Got it.
So, here's just sort of some of the ways we treat aneurysms, right? So this is basically the way I treated that aneurysm, right? I basically put this stent graft in, but we can do other things too. Like we can coil the aneurysm. We can pack a bunch of coils in there to thrombose the thing off, or we can maybe even coil basically the inflow and the outflow to an aneurysm. So there's blood that goes in, there's blood that comes out. What if I just shut down that entire artery and say, no more blood here? Like, let's just stop blood going here. You want to do different things in different cases, right? So in this particular case, I couldn't do that because the rest of the blood was actually supplying the liver. And so you can't just stop the blood that's supplying the liver. That would cause issues. So I needed to keep the rest of the blood open, and in which case a stent graft is a really nice option. Keeps the rest of the blood sort of flowing. All right, so here's another case. I'll go through the last ones a little bit quicker, just so you guys sort of get a feel. So, this is a guy who's coming in with facial swelling and shortness of breath, right? And a couple of things, for pre-meds to notice. He's got a tube down his throat, right? This is a endotracheal tube. So he's being ventilated at this point, right? So he's basically being ventilated, supportive oxygen and supportive respiratory systems, right? So he's hooked up to a big ventilator, which is pumping air into his body. You can see that his face looks pretty swollen, right? His eyes look pretty swollen. He basically, his neck looks big, and he's coming in with this shortness of breath and facial swelling, and had to be intubated because he just essentially couldn't breathe. And this is sort of classic for something that's called SVC syndrome, or superior vena cava syndrome, right? And so you look at this picture, I mean, this is obviously a graphic, but that's kind of exactly what he looks like, right? Like his face is all swollen. And the reason for this is oftentimes that there could be a lung tumor or something along those lines blocking the blood flow from the face back to the heart, right? So blood's got to come back somehow, right? Blood's got to come back from the brain back to the heart to be pumped to the rest of the body. Blood's got to come back from the arms to the brain to the lungs to be pumped to the rest of the body, right? If you had something that's blocking that blood vessel, basically blood backs up. And so in this case, what happens is that there's a tumor blocking, which often can happen, the main blood vessel called the superior vena cava that takes all the blood from the head and brings it back to the heart. And when it blocks, basically that blood backs up. And so what you see is this guy's face getting swollen because blood is essentially backing up, right? It has nowhere to go. At the end of the day, it's all plumbing, right? So it's all just basic plumbing. Blood has nowhere to go. It backs up to his face, and that causes his throat to swell. That causes his eyes to get puffy. That causes his head to get big. That's superior vena cava syndrome. And so this is kind of what a CT scan looks like of that. You can see these are sort of normal lungs. And then you see this gray area here, right? Like that's abnormal lung, basically because he has a big tumor here. And this is the same CT scan, just essentially filtered, right? So this is kind of like an Instagram filter, but an opposite, right? So this is a way for us to see. You can see here, I can see the lungs real well. Here, I don't see the lungs at all, but I see the blood vessels real well. And I can see that there's a clear narrowing of the superior vena cava, right? So this is the blood vessel that should be coming down here. And there's a clear narrowing because of all of this soft tissue there. And so what I would do as an interventional radiologist, I do a venogram, right? And so I come in, and in this case, I actually come in from the groin, and I do this injection. So forget the right side for a second. Look at the left side, right? When I do this injection, what you see is all these blood vessels that shouldn't be there, right? They're going up to the face essentially. And so essentially what you're having is a backup of blood through the system, right? They're going back up the system. So instead of blood going from here down here, it's actually going from here up here, right? And so that's what's causing the backup. And so what I did here was place a stent. The minute I place a stent and inject that contrast again, you see all of these things are gone, right? Now blood flows directly down into the heart the way it should. And so this is an SVC stenting, a very common condition that we deal with and something that we stent all the time, depending on the pathology of this. So what's really cool about this is that oftentimes immediately you see a big result, right? And so this is that same patient 10 minutes after the stenting, and you can see already, look how much better his face is, right? Look how much better his eyes are, that all that swelling is gone instantly because the blood now has a way and a pathway to go forward back into the heart. So that, it's a very simple, relatively simple and quick procedure that we can do, but it can really make a tremendous impact and obviously, really save a patient from being essentially dead because he can't breathe. This guy can't breathe at the end of the day with this. Make sense?
Right.
Yep.
This is a similar case, but in one which we treat quite differently. So you can see this is a right hand and a left hand, right? And you can see that right hand is huge, right, compared to the left. So he's got arm swelling. And the reason he has arm swelling is because he's a dialysis patient and has had different, basically a graft created up here. So dialysis patients need their blood filtered through a dialysis machine, right? And for that to happen, they need blood to be taken in and out of their system. And oftentimes you create what's called a fistula. The surgeons will create a fistula in order to do that. Now, what happens over time is, unfortunately, these fistulas sort of close down. And this is one of the big problems with diabetic patients who end up on dialysis and what's called end-stage renal disease. They basically have issues with their venous access and their flow, and they can't get dialysis in the way that they want. What happened in this case is similar to the last case, but instead of the tumor sort of growing over the course of maybe weeks to months, this is something that actually happens over the course of years. And so you see when we inject contrast, what you're seeing here is this is the chest, right? Can you make out the ribs here? These are ribs, right? And so these are ribs. This is the heart, okay? And then this is the arm. So this guy's arm is out this way. And what we're looking at is essentially this area right here. And so when you inject contrast, what you see is that normally the contrast should come this way, right? It should all the blood should flow from the arm back to the heart, right? It should flow back this way. But in his case, it doesn't. It actually ends up flowing the opposite way, right? So it flows through these tiny little collateral veins, is what we call them, all the way back to the heart. But that causes his arm to swell, right? Because he's got all these veins, essentially. Again, it's a plumbing problem. The blood can't get from one side to the other. And so you can see that's essentially where the blood stops. And this is the same X-ray sort of with the bones, so you can see a little better, so you can understand where you are, right? This is the shoulder, right here. And so this is everything that's backing up. And you can see why his arm is sort of swelling because of all these different things. And so what can I do as an IR, right? So what I did was I basically created a new pathway, right? So I essentially came from the groin and I came from the arm. And I said, how am I going to connect these two dots? Right? Because that's what I got to do, right? At some point, this guy had these dots connected, right? The normal, essentially, brachiocephalic and superior vena cava should come this way, but they've scarred down over time to nothing, which can happen. Basically, these veins can scar down. And so what I did was I took this point, and I took this point, and again, with my really long needle, I basically connected the two. And so I took a super long needle from the groin, I basically connected it to this point up here, and I grabbed it and I said, okay, now I have a connection. And once I have that connection, well, I can do anything I want. So this is actually the needle. It's like this very thin, long needle, right? So it's 65 centimeters. So it's pretty long, very thin. And essentially I stuck it from the groin all the way to here. And then once I have that, well, now I can place a stent there, right? So once I place that stent, all the blood flow comes back. So instead of all those things that you saw, the blood flow comes back the way it's supposed to, right? So that's like it's similar to the TIPS procedure in some ways, but it's in a completely different part of the body. It's completely different indication. But when I said that IRs basically have this like procedural skill set, this is sort of what I'm talking about. Like we can do all these different things in different parts of the body.
This might be a dumb question, but I'm just like, when you're running a wire through veins, are you ever scared you're going to puncture the vein? I mean, how well do those hold up when you're moving things through them?
It's a great question. So definitely. So we're always scared that we're going to come out of the vein or come out of come out of the artery. Sometimes we want to do that on purpose, right? In this case, I definitely wanted to come out of the vein on purpose because there was no more vein left. So I needed to come out. But I have to do it in a way that makes sense, that I can control and make sure I have a backup option, right? So you can perforate out of an artery and you can run into situations where it's an issue, right? So you perforate out of an artery and now you've caused bleeding in that area. What you have to do is have backup options, right? Maybe I stent it, maybe I balloon it, maybe I understand that it's happening right then and there, and I can treat it because I'm right there. But that definitely can happen.
Okay.
And so this is that sort of normal connection. And then one last case, right? So, I said that we treat all kinds of different conditions, and I've talked a lot about endovascular stuff, but here's something that's totally not endovascular, right? This is something that is outside, this is actually in the realm of bones and orthopedic surgery, but we do this too, right? So this is a female who fell and she had back pain, and basically she required narcotics, and she was found to have a spinal compression fracture, which is basically a compression of the spine, right? And so I said that, one of the specialties I was considering when I was a med student was ortho, and it's kind of cool because I kind of get to do some ortho now too. Basically, we can treat this. So when the bone in the spinal column fractures, we can actually go in there through X-ray guidance, put up a balloon, and then fill it with cement. This is a procedure called a kyphoplasty, right? So this is what it looks like. This is what's called an MRI. An MRI is like a CT scan, but actually a little bit different. It sort of uses different physics and is able to give you a lot of soft tissue detail. And what you see here is this is the spinal cord, right? So you see all that white, that's the spinal cord. You see these like little square-shaped things. Those are the vertebral bodies, right? So those are each vertebral bodies. And what you'll notice is that this one vertebral body kind of looks a little bit squished and is bright, right? And so it's got what's called water in it. It's got edema in it. And that tells us that, hey, this thing is fractured. So this is a fractured vertebral body, and this is what's causing her pain, right? When you ask her where her pain is, she says it's right here. She points just to that place. And this can be really painful for patients, right? You can imagine if their spinal column is cracked, it's painful. So what I can do as an IR is essentially go in and find that vertebral body, right? So I look on X-ray, I find the right place, and I put a needle into that area. Through that needle, I essentially make it bigger and bigger and bigger until I can get a balloon in that area. I inflate the balloon to give myself a little bit of height, and then I fill the thing with cement to harden it up. So it's kind of like, if you broke your wrist, you might get a metal plate there, right? In order to fixate it. That's essentially what we're doing for this patient. And it's great because patients, like this patient was in horrendous pain, couldn't get up. And she sees me back in clinic 2 days later, and this is what she looks like. She says, look at me, I'm able to get up. I'm feeling great. Like, so these are the things that, are so satisfying, right? We came back and we talked about, like, at the end of the day, helping somebody and sort of making that impact. And I really feel like, we obviously do that as physicians, as IRs, for sure. So, I went through a bunch of cases there, but the idea was to give you a little bit of flavor of maybe, what an interventional radiologist does and how we do it on a daily basis.
Nice. That's very impressive, honestly. Like, it's really
it's
cool
awesome.
What kind of things IRs can do.
Especially that last one. I mean, that you're going from one day where you can't really walk or, you're in so much pain to being able to do a lot more. It's very amazing.
Yeah, you could definitely make an immediate impact. And I think that's, as you're thinking through shadowing different specialties and looking at it, like there are some specialties that have very long-term impact, and that's fantastic, right? Internal medicine, family medicine docs, like these guys have long-term relationships with patients. They see them over time, psychiatry, right? And you see sort of progress and disease management that way. And then there are other specialties that are very much in the moment, right? And I feel like IR is an in the moment specialty for the most part, where you see a patient, they have some issue, you treat them, you see them in follow-up, and then they're sort of discharged from your care. There are other specialties like that too, right? Like orthopedic surgery, maybe, right? Somebody comes in with a broken wrist, you treat them for that, and then you sort of see them just for that problem, and then they're gone from your care. So that's a decision point for students to make, right? For med students. in particular, like which one do I like? Do I like that longitudinal care, which has so many benefits, or do I like the short-term care, which also has so many benefits, and different people might like different things?
Right.
Very good. Well, Dr. Mehta, I want to say thank you again for joining us. I think it was really interesting, and I hope that pre-meds really find it as interesting as I did.
Thank you so much, Dr. Mehta.
No problem. Thank you, guys. If any of you guys have questions or anything I can answer, feel free to drop me a message through whatever means MedSchoolCoach has. Happy to sort of talk through.
Thank you for listening to the Virtual Shadowing Podcast, powered by MedSchoolCoach. Watch each physician present their cases, along with fascinating images and visuals at shadowing.medschoolcoach.com. There, you will also find a quiz that accompanies each specialty.